Yes, hello class. In this lecture, we're actually going to present. We're actually going to present or discuss this lecture, which should be studied during your lab this week for Thanksgiving. So again, for Wednesday and Friday lab. Okay, so we're going to cover a couple of lectures during this lab, which will be one of them on shoulder and the other lecture on chest wall trauma. So they're relatively short lectures, so they should be, kind of like substitute that lab. Okay, so let's talk about proximal humeral fractures. They're quite common, and what you find that they're mostly common in, if you like, two kind of types of patients. So older, elderly sort of osteoporotic patients with decreased mineral bone density, so certainly patients older than 65. And then you can have potentially very young patients due to high energy trauma. In sort of older osteoporotic patients, usually there's low energy trauma. Majority sort of occur as house sort of like falls in at home. Again, most of them occur in female patients because of osteoporosis, and majority of those proximal humeral or humeral hand fractures, they are considered to be stable, again for that reason, because they're usually low energy trauma. But there's a degree of variation. So we have complications of that. Potentially can be some avascular necrosis, and then obviously further disability in those patients. So we have a nice classification. It's called NEAR classification. What it considers, NEAR, it was an orthopedic surgeon from the East Coast somewhere. I can't remember. It's either Boston or one of those eastern coasts of Maryland, some of this East Coast of the United States. And so NEAR proposed a very good type of classification, which again kind of prognosticates certain clinical, if you like, clinical management of these patients. So NEAR considered, if you look at proximal humeral regions, so we consider, if you like, those anatomical regions where the humerus in fact ossifies. So where we get that sort of, if you like, kind of like growth centers. So let's change that pointer. So typically what we can divide it at these growth centers into different areas, such as articular surface, then greater tuberosity, and then you can have lesser tuberosity, and then obviously surgical neck. So some of those growth centers again also represent like weak anatomical spots. Kind of similar concept that we already talked about in terms of atlas fracture. So those are kind of your ossification centers, so they're considered to be sort of weak spots. So when fractures occur, we typically grade them in terms of NEAR classification into what we call 4 parts differently. Typically part 1, part 2, part 3, and part 4. So typically what we consider we don't really care how many fracture fragments or how many fracture lines are present, as long as there's no degree of any displacement, and or rather the displacement or some sort of lack of alignment less than 1 centimeter and less than 45 degrees, it will be considered as NEAR part 1 fracture. So the majority of those proximal humeral fractures considered to be rather fall into category of that part 1 fracture, because they're very minimally or undisplaced. Sometimes can be very difficult to diagnose on by radiography. Now 2-part NEAR will be typically if you have again usually 1 fragment, perhaps it could be greater tuberosity, sometimes certain variation. In fact, most commonly it's usually surgical neck, but typically if there's any sort of degree of displacement, such as 1 part, for instance, of 1 fragment can be seen with more than 1 centimeter displacement or 45-degree angulation, that would be considered to be 2-part NEAR. And if you see, for instance, 2 fragments typically related to greater and lesser tuberosity, perhaps, and so this way, like sort of intertuberosity fracture, both tuberosity fracture, we can consider that as being NEAR part 3. And of course NEAR part 4 is going to be very severe, and then typically you can see potentially tuberosity fracture, but also articular surface fracture, so fragments, like 3 fragments may be displaced and fractured, so that would be considered as NEAR part 4. And like I said, the majority of them over 80% will be minimally displaced, falling into category of near part 1, and part 4 will be the the least likely kind of clinical presentation of these patients. So luckily, most of these undisplaced fractures, such as part 1 near fracture, they're usually treated with just simple immobilization in those patients, so no surgical treatment. So they can be just immobilized, sometimes in the sling, and sort of like and quickly rehab, and rather returning this patient to activity can be undertaken once some sort of fracture healing occurred. Now, more complex cases, such as near 3 and 4, can be treated, or rather should be treated, with oftentimes with either hemi or complete arthroplastic of the shoulder. So basically, in these slides, you can see everything I already mentioned to you. You can just, guys, read it here. So let's look at some of this sort of scenario. One thing I just wanted to bring to your attention, in your textbook, occasionally you see that sort of term known as a flap fracture. Well, it's not sort of widely published in medical literature or radiology literature, but I just mention it just in case if boards ask you about this question. So flap fracture typically refer to tuberosity fracture, great tuberosity fracture, perhaps an avulsion which can occur, so they call it sort of a flap fracture. Again, it's usually doesn't make sort of any significant clinical prediction, so it just describes the appearance, but it doesn't tell us whether it's displaced and non-displaced, whether it's near part 1, etc. For that reason, we don't know whether treatment should be surgical or non-surgical, as you can appreciate. So for that reason, I didn't quite use that in our terminology, but I certainly mentioned for you to be aware and perhaps kind of remember the term by the time you're taking board exams, etc. Okay, so let's look at this situation here. So you can see a view of the shoulder. You can see an arrow pointing to some sort of osseous fragment, which likely traumatically occurred as some sort of avulsion by some of those important, perhaps from the greater tuberosity. And you can see perhaps due to impact on the shoulder, you may have that sort of like an avulsive injury by some of the supraspinatus muscle, or perhaps some of the ligaments, such as some of those glenohumeral ligaments, etc. So that avulsion followed, but if we can say, is it what part 3? What's the clinical significance? Can it be just treated conservatively? Well, no, because the significant displacement is noted. It's certainly displaced more than 1 centimeter, and then so it's certainly not part 1, but it's typically part 2 near. So in this case, some kind of surgical pinning might be required in these cases. In this case, you can see some of this sort of minimally displaced type of injury. You can see a fracture line sort of kind of extending through the surgical neck and also affecting one of the tuberosities, greater tuberosity. In this case, you can see typically an impaction type mechanism, probably from direct trauma. So in this case, you can see it's minimally displaced, and we don't really take into account number of fragments in here or lines, because it's undisplaced and minimally displaced, less than 1 centimeter in 45 degrees. So we will consider that as one part near injury. In this case, you can see also impaction in a very similar fashion that I already mentioned. I already showed you previous. It's the same case. You can see on CT scanning and X-ray, 3D reconstruction, coronal slices and the sagittal slices can actually show that appearance of kind of impacted fracture of the greater tuberosity. In this case, actually, it's a different case from the one we see in here, but you can see that that fracture kind of is minimally displaced, though classically undisplaced. That we'll consider as near part 1 fracture. In this case, you can see same kind of impaction fracture noted, minimal degree of displacement, but fracture affects surgical neck and sort of impacted. You can see some sort of shortening of the neck, and you can see how that humeral head kind of impacted that, with tuberosity being kind of impacted as well. So again, minimal displacement indicates part 1 near fracture. In this case, you can see part 2 fracture because of the displacement, surgical neck as well as greater tuberosity. So that's considered to be near part 2 because the displacement is greater to 1 centimeter in 45 degree. In this case, much greater degree of displacement, but we can also see 2 fragments in this case, 1 and 2, so that's considered to be near part 3. and again, two-part fracture with displacement, but it's only a single fragment noted in there, probably along the surgical neck. In fact, quite a good majority of those two-part near fractures actually involve in some form or the other a surgical neck. So again, majority of them tend to affect that surgical neck, as literature shows. In this case, you can see significant displacement along all the articular lines, or rather, growth lines. You can see some greater lesser tuberosity. You can see some of the articular surface in the surgical neck. So, the kind of at least 3 segments are seen. So perhaps putting into category of near 4. Okay, just like in this case, you also can see that. So in these cases, you can see a significant displacement as near 3 and 4. We're talking about some hemiarthroplasty and surgery. So in this case, hemiarthroplasty was performed in order to treat it. And sometimes it's tricky because if that patient is very osteoporotic, this situation may be difficult for that osteoporotic bone to hold that hardware. So maybe a surgical appliance or maybe a different technique can be used in those cases. Okay, but that's how usually 3 and 4 part treated. In this case, you can see young patient, and you can see there's significant degree of violence occur. We know that it's still, skeletally mature patient. You can see a growth plate, but you can see there's significant degree of displacement as well as bayoneting or overriding of this fragment. And that's typically, especially with high energy trauma, as I already mentioned it to you, occurs because of sudden muscle contraction and spasm. So in this case, you can see the impact kind of followed along that surgical neck, but you have the situation because the sudden contraction of the muscles, like let's say deltoid muscle, will kind of pull that fragment, distal fragment up and sort of bring it closer, kind of adduct and pull it up. And then in this case, you can see that a proximal fragment was sort of medially displaced and kind of rotated this way. So that degree of bayoneting or overriding can be quite significant because you may have a nerve, an artery severely compressed in this situation. But that's how we know, like pectoral muscle might pull it towards the body as well. So that's how we know that this injury potentially high energy trauma due to severe displacement of the fragments and due to sudden contraction or spasm of this associated muscle. So certainly wouldn't occur. Just the same in this case, you can see a fracture somewhere in proximal humerus, just kind of distal to the surgical neck. Of course, you can see proximal shaft somewhere in the metadiaphysis area, but you can see quite a significant degree of displacement by the same mechanism. So distal fragment being pulled up by deltoid muscle, and the medial fragments are being sort of pulled towards the thorax by pectoralis muscle, and some maybe some other kind of fibers just kind of bringing it this way. So a classic, actually common mechanism of high energy trauma, with severe displacement of fragments. So certainly care should be immediate because of, again, fear of compressing nerves and arteries, and so on. So let's look at some shoulder dislocation. Shoulder is actually quite commonly dislocated because we know that mobility of the shoulder is great, and it's usually sacrificed for stability. So shoulder is a relatively unstable joint, and we know that primarily stability is provided by perhaps rotator cuff, but also some of those important capsular ligaments such as glenohumeral ligaments, especially with that inferior glenohumeral ligaments, a thicker portion that tends to kind of overlie that inferiorly as that axillary pouch. But we know that middle glenohumeral ligaments are very weak, and some of these fibers quite weak, and for that reason shoulder classically dislocates anterior. So anterior shoulder dislocation is the most common, and out of all this anterior shoulder dislocation there's a bit of variation, but most common location is going to be subcoracoid. So it kind of dislocates anteriorly, and then it sort of positions itself right as it's shown here, subcoracoid. Now a couple of variations also present with anterior shoulder dislocation. You may have more rarely than subcoracoid, less frequent, but it may be sometimes subglenoid, so in other words humeral head can position below the glenoid, and on very few occasions, very rarely, it can be sometimes even subclavicular. So in other words, the humerus can sort of anterior dislocate and position at the clavicle. But most commonly, it's going to be typically anterior shoulder dislocation with subcoracoid position. Now, there's also posterior shoulder dislocation, which is much less frequent than the anterior shoulder dislocation. Only about 10% of those, 12% of those perhaps considered as posterior dislocation, and they have few important associations to remember. Typically, posterior shoulder dislocation associated with perhaps electrocution, some sort of electrical shock, but also some epileptic grand mal or some sort of intense epileptic seizures, when that sort of acute muscle contraction and tetanic muscle contractions will lead to often bilateral posterior dislocation in the shoulder. Now, when we have the dislocation in the shoulder, we should also appreciate the fact that all the connective tissues are typically damaged. Yes, so they're going to be ripped, some of these capsular ligaments, perhaps the rotator cuff muscle. So we have to kind of consider multiple, if you like, collateral damage to some of the surrounding tissues, including articular cartilage. For that reason, we're going to look at a couple of those important clinical scenarios that occur. So let's look at this case. You can see patient with anterior shoulder dislocation. That's just, perhaps some sort of portal, central lines, perhaps administer, maybe some sort of chemotherapy treatment or something like that through the subclavian vein, but it's unrelated to current injury. So what we see, perhaps a previous fall, and typically the fall is sort of like, extend hand, or rather outstretched hand in the extremity, but it's usually with the component of extension at the shoulder and external rotation. So most of the time that humerus will be kind of dislocated and then stuck in that sort of anterior and also external rotation position. That kind of helps to look at the position or shape of the glenoid. In this case, you can see how extreme internal rotation produced that sort of roundedness and the greater tuberosity seen in profile. But you can see location, right? Subcoracoid vacating that glenohumeral joint. That's kind of classic. So we need to remember a couple of those complications that potentially develop, which I'm going to talk about in just a minute. Here it just shows different types of maneuver. This is now known as a Cocker maneuver. You can actually look it up to see what types of maneuvers are performed for shoulder relocation. But we know that that shoulder need to be relocated relatively quickly because we can sort of anticipate some collateral damage that I'm going to discuss, damage both to bone, cartilage, and then related, structures. So what I'm referring to is something known as Hill-Sachs lesion and then Bankart lesion. So there are different variations. Hill-Sachs is typically, bony lesion. So what happens? Let's look at it. So you can imagine a situation when, normal circumstances, you can see, bicipital groove, etc. So if you get dislocation of that, so typically you can see the severe external rotation will force that that humerus into that external rotation, and then contraction of muscle because it's sort of and the connective tissue starts squeezing that humerus. That typically that posterior and lateral aspect of the humerus, it started kind of approximating and squeezing it against glenoid labrum, and in this case it can lead to like an impaction type fracture that will impact on the greater tuberosity, leading to sort of this very identifiable sort of, if you like, impaction, sometimes called hatchet deformity, that usually affect your greater tuberosity and its posterior aspect. Now, having this injury, the longer you leave it, the worse the injury becomes. So it needs to be relocated swiftly in order to avoid that, because the problem with this injury, once it develops, then patients almost always become like chronic dislocators, because that humeral head will be altered and its sphericity is lost, and typically it is not going to be held very well by that posterior aspect. So typically people will be kind of more frequently dislocated their shoulder following this sort of injury. So in this case, you can see axial CT scanning the patient. You can see lung tissue, ribs, patient kind of lying on their back. You can see that sort of glenoid, and you can see a relatively severe impaction fracture from the glenoid, because probably shoulder hasn't been relocated swiftly enough, and for that reason you end up with this type of severe Hill-Sachs deformity. Now this can be demonstrated in X-ray quite readily. So in this case you can look at the axillary view. You can see that sort of hatchet deformity, and then typically that impaction fracture known as Hill-Sachs lesion, and it's typically affecting that greater tuberosity and then sort of its posterior and lateral aspect of that femoral head next to the tuberosity, and that's the classic of that. Bankart lesion, they're different, is a great degree of variation. So I will be mainly talking about bony Bankart lesion that you're going to see on imaging such as X-ray and CT scanning, but also there's a little bit of variation. There's some sort of what we call soft Bankart or cartilaginous Bankart lesion, which have several different types that only detectable by MR imaging, and sometimes MRI arthrogram can be very, very helpful in those cases. But let's look at it. Let's look at what Bankart lesions are. Typically, what you're going to see on X-ray is typically some sort of impacted type avulsion/injury affecting inferior and anterior rim of the glenoid. So you can see that sort of like a relatively small fracture of different variation, but relatively small fragments. So you need to know what you're looking for, and again, specifically try to find it on radiographic examination of that shoulder dislocation. So that's known as Bankart lesion. Now you can also have the cartilaginous Bankart when it doesn't affect the bone, just a rim of cartilage, a rim of glenoid. So basically it's going to be like pure kind of like soft Bankart or cartilaginous. And of course there can be reverse Bankart that happens more in the posterior shoulder dislocation. But there's a whole different variation, such as the Perthes lesions, also known as anterior labral periosteal sleeve avulsion, and glenoid labrum articular defect. It's basically what you find that in these cases in Perthes lesions, typically glenoid labrum is being detached, or if you like, separated from the underlying glenoid, humerus glenoid, and also your anterior glenohumeral ligament will be sort of, if you like, torn from this attachment. That leads to that sort of situation. In this case, you can see that sort of ulpsated labral periosteal sleeve avulsion, instead of the fragment completely separated, periosteum being stripped, and then that labrum can piecing and overlie it, and the glab it's still attached by the ligaments, but typically cartilage, articular cartilage, along the articular cartilage you'll have some sort of lesion. All this is definitely a MR type of diagnosis, but this obviously bony Bankart can be readily investigated by radiographic imaging, or they're seen by radiographic imaging. So in this case, you can see this patient has both humerus, Hill-Sachs lesion right there, and then has a Bankart lesion, can readily identifiable in this case. Coronal images you can see through CT of the shoulder. You can see relatively large Bankart lesion in this patient with relocated anterior shoulder dislocation. In this case, you can see same evidence. Bankart lesion is present. Obviously, shoulder has been relocated, and that's kind of indicating that potential injury. By the way, just of note, you can see this sort of cystic changes right there along the great tuberosity with if you like, sclerosis or insertional kind of area of sclerosis, subchondral sclerosis, as well as cystic changes. This finding is extremely consistent with the high probability of supraspinatus tendinopathy, tendinosis, or even tear. So it's kind of like a radiographic feature that makes us suspect supraspinatus type pathology quite readily, for which MRI can obviously indicate, or ultrasound for that matter, can actually show supraspinatus pathology extremely well. In this case, you can see Hill-Sachs lesion and relatively subtle Bankart lesion. You can see the outline of this osseous fragment just overlying glenoid because it's kind of approximated, so you're not going to be surprised that maybe occasionally it can be missed by especially non-radiologists kind of interpreting the study. But you can certainly look at this fragment Bankart lesion that is certainly indicating some sort of osseous fracture in there, same as Hill-Sachs type lesion. So in this case, you can see another shoulder dislocation, perhaps some evidence. Again, sometimes X-ray may be equivocal, but in these cases, if concerns present, then perhaps, I question a couple of irregularities there. So again, MRI may be a helpful modality after relocation to look for some of those cartilaginous injuries affecting regions. This is scapular, wide scapular view. You can see that, and that sometimes really helps us to identify or rather differentiate anterior versus posterior dislocation. So typically your glenoid is here. You would expect that humeral head to be aligned in the middle, articulating with glenoid. You can see it's anterior to glenoid, so anterior shoulder dislocation, or glenohumeral dislocation. Posterior glenohumeral dislocation, again, it's less frequent. It only accounts for 4%. I mentioned 10, but it's actually less than that. And typically, what you find that it's again convulsive sort of electrocution, etc., etc. So we'll look at it now. Same as in anterior shoulder dislocation, you typically may encounter some of those damaging situations when the collateral damage often result from that, if you like. If that's not been relocated swiftly enough, it may lead to some of those changes along the humeral head, like impaction fracture. But in this case, it's going to be different parts of the humeral head, because with posterior dislocation, humeral head is going to be extremely or severely internally rotated and then adducted, or rather approximated posterior along the posterior rim of the glenoid. So typically, you're going to find that sort of posterior, sort of like that anterior and lateral aspect of the humeral head, leading to some kind of impaction fracture that typically present as something called a trough sign. So let's look at some of those features. Other features may be reverse Bankart lesion that you already saw on that picture. So in this case, you can see the humerus is in extreme internal rotation, because you can see that sort of appearance of the tuberosity is kind of more inward rotated. You can also see that sort of what we call like a pseudo tumor sometimes, because of that sort of appearance of radiolucent head. But also what you see, in other words, is something called light bulb sign, because that humeral head it very much resembles the actual light bulb in this case. So you can see how the outline, because of extreme internal rotation, may represent that sort of light bulb. Okay, and that's the name sort of light bulb sign. Just tells extreme internal rotation of the humeral head. The other thing you can see is features something known as trough sign, because of the impaction against the posterior rim of the glenoid. You can see that sort of impacted injury will produce that sort of trough sign, or sometimes called as reversed heel sack sign, etc. And maybe considering that bony overlap, there might be some possibility of the reverse Bankart lesion. Now, the other thing is something called also rim signs. So typically, if this distance from the anterior rim of the glenoid to humeral head will be greater than 6 millimeters or 6 millimeters or more, that typically indicates that sort of evidence of the anterior shoulder dislocation. That's what they call it, rim sign, as you can readily see in here. So you can see trough sign produced right there, basically impaction right there. You can see rim sign is basically extreme internal rotation, and then significant distance present between anterior rim of glenoid. And in this case, you can see that light bulb sign because of this sort of configuration of the light bulb. So all these features can be sort of revealed in that area. In other words, another evidence of that rim sign for you to see. Inferior shoulder dislocation, quite infrequent and usually follows severe trauma, and typically it has a name, something called luxatio erecta. And what it actually means, because of the intense, if you like, inferior displacement of the humeral head, it's been completely ruptured some of this thick and strong inferior glenohumeral ligaments. So your humeral head classically vacate that glenoid and being stuck in as if it's being held in abduction. So that's why they call it sort of luxatio erecta. So classically kind of demonstrated in this image. And typically the extremity is also going to be flexed at the elbow, so the person will not sort of be able to move the extremity. Usually follows potential severe injury to some of the nerves and blood vessels in this area, so certainly much more severe than anterior shoulder dislocation, but luckily not very frequent, and certainly you wouldn't anticipate that happening from sort of like the typical fall that your anterior shoulder dislocation occurs. So we're talking about more severe trauma, high energy trauma, requiring ripping all these tissues, and typically, if you like, sort of depressing that humeral head inferiorly, that basically separating it from any inferior sort of glenohumeral restraints, and it just basically falls out of the shoulder with stuck in abduction. So that's basically luxatio erecta. AC joint dislocation are quite common. We're going to look at some of those. So typically there's a nice classification. There's something called Rockwood classification. The reason for that, because that kind of, if you like with all this orthopedic classification, sort of dictates a very different level of care that the patients will get. So how do you obtain the images? Well, if someone had an injury somewhere and you kind of notice that some sort of step perhaps along the acromioclavicular joint, or perhaps just intense pain and inability to move the arm. So x-rays might be helpful, and typically we take radiograph bilaterally, so we take them with and without weights. And then so typically a tube might be, so a couple of images might suffice. So typically it's straight kind of, but also 10 to 15 degree angulation, which can kind of help us to view the clavicle. better. And so you would take it with and without weight. So typically give patients sort of 10-pound weight and then take it, hopefully fitting on one single cassette, both shoulders. And then you can take it with weights, and you can see which joint potentially affected, losing its normal congruity, its normal alignment, and widening of that, especially sort of separation of the acromioclavicular joint and particularly coracoclavicular space widening. So there's a classification. So typically what happens, so Rockwood classification just defines that typically with type 1, it's certainly not evidence on x-ray. You might see some sort of changes on perhaps ultrasound or MRI's high signal intensity, but it's a sprain to acromioclavicular ligaments. So no ligaments are being physically torn. Now type 2 is when AC ligament is being torn by CC or coracoclavicular ligaments. That literally just hold your clavicle to your chest. Basically, clavicle and the entire upper extremity is being held by some of those ligaments to your thorax. So typically, if these ligaments are intact, so we're talking about just ligaments rupturing between your AC joints, that is normally type 2 on Rockwood, and you may see a little bit of widening with very minimal superior translational clavicle. Now type 3 that's the one that is most readily demonstrated in X-ray. And how does it demonstrate it? Well, because both ligaments are ruptured, AC as well as CC ligaments, so clavicle now is completely unopposed, and it will usually, so typically I would look at the undersurface here. This is where alignment I expect it to be, and you can see that sort of rise of that clavicle, and it's usually when it's more than 2 millimeters will be quite suspicious for that grade 3. Now if that rise is significantly higher, like you see in this case, certainly exceeding more than 5 millimeters or 4 millimeters, that typically tells us that some of the muscles are being torn in this case, and that would be kind of indicate type 5, which was a ligamentous but also muscular type of displacement. But most common is typically type 1, 2, and 3. With type 4, 5, and 6 occasionally. With type 4, typically you have that clavicle after all the ligaments being torn. Clavicle can kind of migrate posteriorly, and so the situation that you have, severe compression may develop of some of the blood vessels and nerve. So this could be, so all these cases are surgical. So because these ligaments, especially type 3, these ligaments will not heal without surgical fixation, so they has to be surgically anchored. Some cases, again, this is all surgical cases, type 5 and type 6, when that clavicle everything is being torn, and then the clavicle is being sort of depressed inferiorly. Okay, occasionally you find also clavicular distal end of clavicle fracture may also lead to dislocation in that area, so surgical cases. Now once again you can see some of those variations that on Rockwood classification, and then potential sort of soft tissue complications in that area. Now that's a nice kind of Rockwood classification. Radiographic appearance can also be described here, just like I already mentioned it to you in this case. Okay. So let's look at it. So in this case you can see, so that's where I expected clavicle to be. That certainly that rise significantly signifies some of the type 3 likely to be injury because of the coracoclavicular ligament being ruptured as well as AC ligaments being ruptured. Okay, in this case same situation, you can see coracoclavicular ruptured, and that's grade 3 injury has occurred. In this case, patient had that bilateral radiograph with weights. You can see how this joint looks intact, but this joint certainly some sort of degree of separation, classically indicating grade 3 separation in this case. Clumeral shaft fractures, again, you typically require some sort of high energy trauma. Occasionally you can have a pathological fracture of humeral head due to perhaps primary bone neoplasm, such as young people, maybe enchondroma, older people perhaps metastatic bone disease or multiple myeloma, etc., etc., may potentially lead to this kind of situation. And of course there's a great degree of variation in terms of primary bone lesion, but typically high energy trauma. In older patient, osteoporotic patient, once again, maybe low energy trauma with some sort of either direct fall, if they sort of slip and fall kind of with their body kind of pressing on that shoulder, on the humerus, and then the floor being squeezed, that might lead to some sort of fracture in that area. Occasionally sort of some of the spiral fracture being discussed when there's significant twisting injury to the shoulder, such as discussed like in arm wrestling. Open fracture may also occur because there's relatively short distance, or rather thin distance of soft tissue and the bone. So open fracture, obviously we know multiple sort of complexities associated with them. A couple of names exist. So one of them, I mentioned to near classification for proximal humeral fracture, but certainly the name of the fracture, especially with this sort of classic location when you get fracture through humeral shaft, sometimes it can happen also distal, but because of, if you like, your virus angulation of the distal fragment and kind of lateral displacement of the proximal fragment, you can have that situation when that displacement due to the muscular contraction produce the characteristic appearance. And as you know, because the radial nerve kind of appears from that area just like that in that spiral groove, okay, and so for that reason we know that that rather this way. Okay, and then so we know that potentially radial nerve can be compromised in this area. So occasionally, so this fracture was known as Holston-Lewis fracture. So as I mentioned to you, basically spiral fracture through the shaft with distal fragment displaced in such a way that proximal end will be displaced radially, sort of, i.e. laterally in this case, and by its eponym, so Holston-Lewis, just like this kind of, if you see location of displacement of the proximal humerus. Okay, in this case you can see a spiral fracture kind of occurred in this kind of configuration in this patient. Again, radial nerve injury in this area should be considered. In this case you can see a pathological fracture, so you can see some sort of neoplasm in there. Person is young, so I would expect it to be perhaps an enchondroma, considering this location as well. But who knows, maybe occasionally an aggressive malignancy such as perhaps Ewing sarcoma, primary in a young individual, like in children, or perhaps more metastatic disease in people, or perhaps bone lymphoma or multiple myeloma can also lead to this pathologic fracture. So again, no trauma is required. It may be just sort of a spontaneous or very minimal type of trauma. In children, sometimes benign lesions such as simple bone cyst or unicameral bone cyst may also be the culprit. So thanks very much for this lecture, and we can continue with chest wall trauma.